how do we see whether the way we were seeing pregnant patients earlier or we modify something? And this is exactly, and how do we incorporate telemedicine into these antenatal care, which for last 2 months practicing it, I also feel that it is the essential part of our antenatal care, and probably it is going to be with us for time to come. I need not tell you about universal precaution, that every time, everywhere, every place you need to go through that. What I need to bring to your kind attention, that you must screen your patient when you are, or healthcare worker, for any loss of taste and smell. That those are two new features that has been added. But what is the antenatal visits? Are we sticking on to those 8 visits that has been recommended by WHO for any patient, or should we modify these antenatal visits during this COVID time? So first is, what you need to do is, you need to have risk stratification. Suppose a patient is a high risk patient, so naturally you need to ask the patient to come back early, whereas a low risk patient, which most of them, apart from 10% of high risk pregnant patient, 90% of them will be low risk. So you need to identify these low risk patients, and then these patients can be asked to call to visit the hospital. Instead of 8 times, you can reduce to half the time. That has been recommended now by WHO, CDFD and many centers. That is one at first trimester, that is around 12 weeks. The second one is at 30 weeks. So from 12 weeks to 30 weeks, you need not call the patient, but you have some consultation over telephone. Then at 36 weeks and 40 weeks. So this will reduce your patient load to your clinic. I believe that every hospital is flooded with antenatal patient, and you need to continue this service during this COVID time. How do you identify these risk patients, that they are high risk or low risk? There are different charts available. I have just put up one of them, which we also follow. Low risk is less than 2. So you need to fit into your patient into this chart, and it can be downloaded, and from my slide also you can have a peek and then keep it in your clinic to identify which are the high risk patient. A patient who has been classified as low risk, during the antenatal period, you can still shift her onto high risk if she develops some complication. So there are different scoring system, like, as you can know also, say for example, a patient who has got previous 3 abortion, previous fetal death, neonatal death. These are the patient who puts the patient into the pregnancy into the patient, at least like may have to have frequent visits depending on the condition. So in the antenatal clinic, you can have your assistant who may not be a doctor, who can take weight, blood pressure, pallor, edema and fundal height, which can be measured by an inch tape. Then hemoglobin needs to be done at least 3 times. There are certain investigations that all of you usually do it. Please do not forget to screen the women for diabetes, which is more prevalent these days, and gestational diabetes can be diagnosed by 2 hours blood sugar after giving 75 grams of glucose. So that's one test for all patients, even if it is a low risk or a high risk patient. If it is a high risk, then you need to repeat it at 24 to 28 weeks. But then you need to identify them, because that affects your pregnancy outcome, including the neonatal outcome. Then there are some optional tests. Please do not go after all these optional tests like double marker and quadruple test. Rather put your energy into the routine test that is being recommended by all the bodies. So like malformation scan, one scan, everybody recommends to rule out malformation, that is to be done between 18 to 20 weeks. And we may have rule out hemoglobinopathies in a woman who is anemic, or if it is a policy for screen all pregnant women. So there are some optional tests and there are some definite tests that has to be done during pregnancy. And after doing these tests, you can see these reports on online or tele consultation, and then accordingly call the patient for subsequent follow-up. Most of the antenatal care during this COVID period, this has been, even FPA has published it in April 2020. They are trying to modify it, but then one major thing is that you need to decrease the patient load, and then hence you need to triage your patient, limit the number of women attending antenatal clinic. You may have to extend your clinic time. Say you may have to start early and finish late, but then the patient has to be dispersed in over the period. Then they should not attend any emergency, or they should not come through any fever clinic to your clinic, and they should not be accompanied by a lot of relatives. Even we also insist on not having even the any of the relative to our antenatal clinic. If it is only essential to have a talk with the partner or the couple or any other relative, it can be done over telephone. And you can practice one-stop contact, that a patient can have an antenatal visit, can give her blood test for investigation, can have an ultrasound examination on the same day when she visits your clinic or visits the hospital. So that way we can reduce the patient burden to our clinic. We can reduce the transmission between two patients, and that will probably take care of antenatal patient. So we have formulated Tele Consultation that will be circulated to you all. What we intend to do that is we will be giving services to patient as well as to the doctors who need it. For doctors, we have WhatsApp number and a time fixed from Monday to Saturday. Say for example, doctors have been fixed from 1 to 3 p.m. But then please send the documents of the patient so that we can go through those documents and then decide what is to be done for that patient, and hence our interaction can be crisp and clear. So that way, and for patients, we have kept it from morning till evening, and they can contact us so that we can help them out. Once they contact us and then we want to discuss them, then there is some platform like Zoom or WhatsApp platform where patient can be counseled and they need not come to SGPGI for a physical visit. It's only required to have a physical visit if it is essential to have a service from us. Otherwise, if it can be managed by all of you, we will be more than happy, and we will be there to assist you in managing these complicated antenatal patients. There are few conditions where you need a help from us or a physical visit of the patient for us. It has to be with appointment. So thank you all for this listening.